Malik Kahook, I think most of you know, is Professor and Vice Chair, Department of Ophthalmology, Chief of the Glaucoma Service at the University of Colorado. He chairs the Orbis International Medical Advisory Committee. He's a consultant to the FDA's Ophthalmic Device Division. He has developed over 150 patents, but I think very importantly, 50 plus of those have been licensed, so they're important patents. His devices that he's helped develop include something I use in surgery quite frequently, his dual blade for helping us perform angle surgery for patients with open angle glaucoma, as well as the Harmony modular intraocular lens system. He was awarded as the new Inventor of the Year at the University of Colorado in 2009, Inventor of the Year in 2010. He's ranked second on the top top 40, under 40 back in 2015, and named top 10, again, list, ophthalmology power list. And he's been many other awards from the American Glaucoma Society and the American Academy of Ophthalmology. It is my privilege to have introduce Malik Kahook. He'll talk to us on sustained drug delivery for glaucoma, from promise to reality. And Malik, before you begin, let me present this token, this plaque, this small token of our appreciation.
Just kind of want to leave the room after an introduction like that. It's all downhill from here. So I want to reciprocate here and just talk a little bit about the Glaucoma 360 New Horizon Forum, Glaucoma Research Foundation staff, led by Adrian and Andrew. I had the pleasure of working with this group on the program committee for at least 6, maybe 7 years, and I can attest to their professionalism and their dedication to putting on an excellent meeting. And Andrew promised me an extra minute in my talk for each year that I gave service to the foundation. These are my financial disclosures. So as Andrew said, I'll be talking about sustained drug delivery for glaucoma, from promise to reality. I'll talk about current realities of adherence to prescribed topical therapies with a focus on the studies that we've done at the University of Colorado. I'll talk about the pros and cons of different systems that are being studied and in use today. And then I'll finish off the last half of the talk with things that we're doing at the University of Colorado, an office-based drug delivery system, and then I'll talk about the Spyglass Pharma system towards the end. So a lot of you have probably heard of ChatGPT, this AI system that you can actually have a conversation with, back and forth with giving input. And before this talk, I asked a simple question about what the unmet need is in drug delivery. And I can tell you the unmet need is not the fact that we need more medications that can lower intraocular pressure better, because we have really great medications, great classes of medications. But this is what ChatGPT said. We currently lack pharmaceutical methods for treating ocular diseases with precision and efficacy, where drugs are delivered directly to the targeted tissues and where patients experience fewer side effects. And then I added this last part, without compromises. And the major compromise with topical therapeutics is the issue of adherence. We know that adherence to glaucoma therapies, in particular, if you compare it to other systemic diseases, is poor, with reported rates of non-adherence ranging between 30 and 80%. And I can tell you in all of our studies, it's much closer to 80% than 30%. Non-adherence can lead to complications, disease progression, and vision loss. This is the treatment algorithm that I used when I was first in training. This goes back 20 years. In the past, due to limitations of choices, disease progression was the driver for the treatment algorithm decisions. So we always started off with medications, went to laser, and then went to filtration surgery. This all got flipped upside down when MIGS devices were introduced about a decade ago. So the choices that we do now are based on age, IOP, visual field status, type of glaucoma, a much more nuanced approach to doing things. However, most of these advances have been surgical, despite the existence of excellent medication choices. And despite these new approaches, only a minority of cataract surgeons, and let that sink in for a bit, only a minority of cataract surgeons are actually performing angle surgery. We talk about it a lot in meetings, but most cataract surgeons are actually on the sidelines of doing angle surgery. So let's go back to adherence and talk about how we got to where we are today. In 2007, after I finished fellowship, I went to the University of Colorado, and I did fellowship with Joel Schumann, who's in the crowd here. So thanks, Joel, for everything that you've done in training me. And I started doing work on adherence, and I got a grant from the American Glaucoma Society to do this. And these are the list of common things that lead to poor adherence. The one thing that caught my eye was the inability to identify the correct bottle. And when we talk as physicians amongst each other, and also when we communicate with patients, We talk about cap color to designate the category medication. So for example, a yellow cap color usually designates a beta blocker, and I think a lot of us in the room are familiar with that. But the big question is, how do patients actually communicate with us, and how do they communicate at home about which drop to use if they're on more than one drop? And so we did a questionnaire. One of our medical students at the time, Catherine Mirando, who's now a glaucoma specialist, asked 126 patients how they identify their bottle if they're using more than one. And I think not surprising to any of us, most of them said by the cap color, and number two was the bottle shape and size. Took it one step further, and we combined our efforts with Pradeep Ramalu at Hopkins, and we did things a little bit differently to tease out the communication that might happen between a physician and a patient. We took 11 bottle caps, different colors, and we presented the colors to 100 patients. And in reply to those 11 different cap colors, they came back with 102 unique color descriptors. So it was a really interesting response to get. We then took those 102 unique descriptors and we showed it to 3 physicians, and we tried to see if the physicians could guess which medication the patient was talking about. And the majority of the time, the 3 physicians could not agree on what the patient was talking about. So the method that we're using to communicate with patients is not perfect, and you can add another layer on top of this where compounding pharmacies sometimes are giving out drops that have a yellow cap color for something that's other than a beta blocker, in this case a combo medication. Bottle shape can be different. We were used to the flat bottle for latanoprost, now you have round bottles. Cap color and bottle characteristics are examples of the complexity of adherence to therapy. So can we find ways to make this better? One easy way is to go from 2 drop bottles to 1, right, to just simplify the regimen. Reminders, a lot of the in the room here are former Alcon people. You remember the Travitan dosing aid that we had for a short period of time on the market. And then physical aids, helping to position things on top of the eye so that the drop gets in. But adherence aids have not adequately addressed the human factors and have not been widely adopted. I think that's just a fact. So where do we go from here? One way we can go is using gap therapy, or guided administration of pharmaceuticals that are patient-independent, physician-administered, and device-guided. This would be my wish list. I've used this in previous talks. Patient-independent, I want the physician to be in control. Safety and efficacy, that's at least equal to, preferably better than a PGA. Long duration of efficacy, if it's done in the office, I want it to be at least 3 months of efficacy. And if it's done in the operating room, personally, I want it to be more than 24 months because you're not going to go back to the operating room every year. It has to be repeatable over the lifetime of the patient because glaucoma is a chronic disease and we treat other chronic diseases, and 100% adherence. These are the categories of different gap therapies that are either in research, development, or on the market today, and I'm going to touch on each one of these briefly. Now, the pros for all of these are remarkable, and I want to say that right off the bat, and they're similar across the different categories. Non-invasive for many of them, physician-administered, and patient-independent. On the con side for punctal plugs, which have been around for drug delivery for multiple decades, the retention has been poor, unfortunately, so they have a tendency to fall out. Less effective than timolol in the available studies, and that's partially because of passive delivery. It depends on tears getting into the reservoir and coming back onto the ocular surface. And there are, of course, safety issues if these plugs fall out and the patients don't know and they go without therapy for a long period of time. Subconjunctival injections, perhaps the oldest form of drug delivery that we've used, the same pros as the previous slide, but it is invasive, and the inconsistent delivery happens because drugs actually leak out from the tract of injection. Frequent re-injections are historically needed, and scarring of the conjunctiva, of course, occurs with multiple injections, and that's not desirable because that's our main method for treating advanced glaucoma with filtration surgery. My son walked in when I was looking at this video, and he's like, "Dad, not cool. What's going on here?" And I said, "No, you don't understand. This is Gene Dewan doing this, world-famous ophthalmologist, right?" And he's like, "I don't care. Not cool." Walked back out. 100% adherence, low dropout rate, 6-month delivery. This is a fantastic device. I know Ann Rubin's in the crowd here, and I think the team did a remarkable job. It does have a little bit of discomfort. Cosmetically, people notice when the patient has this in. In prior studies, it was shown to be not as effective as timolol, but I do hope that Allergan can push this forward in some way. Allergan ended up acquiring this technology in large part because of things that happen at this meeting. So there are a lot of nice side sessions that happen here. Intraocular depots, same pros as before. From a con side, it is invasive. You're injecting something into the eye. Require re-injections every 3 to 4 months. Requires a procedure room, so it's not something that you can do in the office slit lamp setting for most people. And then the endothelial cell loss limits the re-injection. Unfortunately, the label for the only approved drug depot, Durista, has a limitation from a re-injection standpoint. This is with Allergan. I trust that Allergan's going to do a good job at expanding this label because they do things very well. One slide here, I was talking to Tomas before I got up on this podium, and he told me that he's going to talk about iDose, so I'll just be very brief here that the pros are very obvious. Glaukos does a great job with implantables in the angle, so I expect great things from this. It is invasive. The actual load is about a year, so the drug load is about a year, so we'll have to see as far as how often you have to go back to the operating room, what's the duration of efficacy. This largely is not public at this point. Proper placement is a must, and as I started earlier in the talk, most surgeons are on the sidelines of angle surgery. So we're not hitting my entire wish list, but we're doing a really good job at hitting most of these points. Safety and efficacy equal to a PGA, and long duration of efficacy with what we have available to us, we're just not quite hitting it. We talk about what patients want, maybe sparingly at a lot of these meetings. We talk a lot about what physicians want, but let's talk a little bit about patient acceptance. So we did a study in 2016 asking 126 patients in my clinic, what would it take for them to move from their drop therapy to something that's more invasive, maybe an insert or a punctal plug or something that's an injectable. And despite an overall desire to avoid more invasive therapies, 45% of patients were accepting of more invasive approaches to decrease or avoid the use of topical glaucoma medications. That, to me, is very encouraging. We took it one step further, again, teaming up with Pradeep Ramalu, and we asked 150 patients a similar question to tease out some of the nuances here. And we found that most glaucoma patients considered sustained drug delivery modalities acceptable alternatives to eye drops, but only when they were said to obviate added surgery, which is a key point with drug delivery. So if it was happening at the time of cataract surgery, they were much more accepting. You can think sort of the MIGS category for this, very similar, or demonstrated greater efficacy than eye drops. So we've talked about different ways to deal with patients who might not be adhering to their therapy, but is that enough? Is patient motivation enough, or do human factors typically get in the way? I'm going to play this video here for you to watch.
My asthma. They said they'd fix it, but it didn't make any difference at all.
Well, sometimes doctors make mistakes. Anna, you have to try twice as hard to fix them. Are you using your inhaler?
All the time. Go through one a week.
You sure you're using it right?
Do I look like an idiot?
No. Why don't you show me how your inhaler works?
So, here's the thing. We laugh in this room about things like this, and it's good to laugh about serious things. I think it's good to take a break and laugh. But if you want to laugh really hard, go to your ophthalmologist and ask them to put drops in their eyes and see what's funny. So the study was done to assess the effect of patient education on videotape topical drop installation technique. Drop installations were recorded, followed by an educational session. Then 30 minutes later, the drop installation was recorded again, and these are the variables we looked at. Drops instilled on each day, drops reaching the ocular surface, and then does the tip of the bottle actually touch something it's not supposed to. This is a patient where we said, put a drop in your left eye, and she wasn't sure. She got a little bit confused, left versus right. And you can see there are multiple touches of the eyelid, of the eyeball itself, and we counted about 7 drops actually coming out of the bottle when we asked her to put 1 drop on the eye. So after an educational session, 30 minutes later, we repeated this, and she does a little bit better. She's using her left hand to try and pivot, but you can see she's still touching the eyeball, she's still touching the eyelid, and you still get several drops coming out. We did a little bit better. We got proper installation from 66% to 82%, but our conclusion was that many, likely most patients can't use drops appropriately, so motivation just isn't enough in many cases. So let's talk about some solutions. Patient-independent drug delivery solutions. Can the promise become a reality? I'll talk about one of the devices from our laboratory. We call it the CU lacrimal system drug delivery device. If somebody's in marketing, you can think of a snappier name for me, because that's not it. So the lacrimal drainage device is a natural reservoir. It's been used for decades to deliver drug to the ocular surface. This is our solution, an animation that I'll show you where the device approaches the punctum. It then enters into the punctum and through the canalicular system. The unfilled reservoir then resides within the nasolacrimal sac, and that reservoir is then filled with medication. It can be many different types of medications to target different diseases. As the introducer is then pulled out, a plug is put in place to limit the flow from the active reservoir to the tear film. Dimensionally, this is equivalent to a conventional punctal plug. The dual lumen for controlling inflation and elution is in place with the dispensable balloon acting as a reservoir and driving constant flow. So very different than traditional punctal plugs for drug delivery. There's a proprietary gel matrix controlling the elution rate, and that gel matrix can actually be tuned to what time, duration, API we're targeting. What I love about this is it's enhancing the retention naturally because of the balloon reservoir, so you're not going to get the dropout rate of past approaches, and the constant long-term active delivery is key. We've done years of preclinical testing, did a lot of this with Andy Schieber at Ingenieris, who some of you know and work with, and we just recently finished the first clinical trial going in to put this into patients bilaterally to assess comfort, and we found this to be very comfortable for patients. And this is allowing us to go to the next stage of targeting glaucoma to begin with, but you can also put allergy, post-operative drops in this. The solution addresses many of the issues of past depots. It's accessible to both physicians and optometrists in the office. Granted patents and a clear regulatory and reimbursement pathway has us accelerating forward, and we're just now exploring next steps for this technology that resides within the university. And I'll finish off with talking about Spyglass Pharma, which might be new to a lot of you in the room. We haven't really been public about Spyglass. 20% of cataract surgeries are done in eyes that also have glaucoma or ocular hypertension. There's low friction for patients and surgeons to take care of glaucoma while doing cataract surgery. And the question is, what is the Spyglass Pharma drug delivery platform? We use a standard intraocular lens with a slight modification at the haptic-optic junction that receives 2 drug delivery pads. These are then put into a standard injector off the shelf. Once it's in place, it can go through a standard sub 2.4 millimeter incision. In post-cataract surgery, the platform goes into the capsular bag where it can safely deliver drug and a payload of 3 years. This is about 3 years of work condensed into one slide, just to say that we validated the system in vitro and we've done multiple animal models for in vivo testing. All looks great. And we just recently started our first in-human study where we enrolled 23 subjects. Baseline washout pressure was done, and these were patients who had mild to moderate open-angle glaucoma or ocular hypertension. We presented the 3-month data at the American Academy of Ophthalmology, and you can see that on the grid here. And for the first time today, I'm presenting the 6-month data showing 45% mean IOP reduction across all of the doses at 6 months. And perhaps more remarkable, the fact that all patients are off topical IOP-lowering therapy through the 6 months. Now, if I go back to the wish list, of course, this is biased because it's my wish list. I can tell you that we're hitting all of these right now. Efficacy and safety equal to or, in fact, better than a prostaglandin analog, and the long term of duration with a payload over 3 years to me is very exciting. This is our pipeline looking at different therapeutics. We're starting off with bimatoprost, but moving on to addressing chronic uveitis and even a platform for AMD. We also have a Gen 2 device that teams up well with our Gen 1 device for continuous delivery every 3 years or so. This is the team. Patrick Mooney, the CEO of Spyglass, is actually in the room here. I think a lot of you know him. We hired him as CEO a couple of years ago, and you can see the rest of the team. Glenn Sussman is my co-founder, and James Denowell rounds up the team as COO. And these are our investors. Cynthia Yee is actually on one of the panels today, so I just wanted to thank her for the support. And you can see a lot of the advisory board members are people that you guys know well. We're submitting the IND this year. Phase 1/2 is starting this year. And I say next fundraising, but we're always fundraising, just like any startup. So we're in constant fundraising mode. I'll finish off with this slide here and then just do a complete summary at the end. The Spyglass drug delivery platform is a new vertical in the IOL space. It has the potential for longest duration of delivery compared to other sustained drug delivery devices that are in development or on the market. There's no risk of additional endothelial cell loss from the safety of the capsular bag. It has an established regulatory and reimbursement pathway, and the key here is this is accessible to all cataract surgeons. I started off with ChatGPT, and I'm going to close with ChatGPT. I took the transcript basically from this talk, and I put it into ChatGPT, and I say, hey, what do you think about a conclusion? And I love what it gave me back. Drug delivery is a rapidly advancing field, great promise. The handful of technologies and strategies are being developed to make drug delivery more targeted, efficient, effective. These last 2 points, I think, really tell you about the beauty of this meeting in particular. Clinicians, the stakeholders for this, clinicians, researchers, regulatory experts, and industry members, as well as investors, basically everybody that's in this room is important to advancing this field forward. And then it closes off with really part of the title of my talk, which is "The Promise is Now Reality." Thank you very much.